Okay. Super. Yes, yes, I do have some time after that if because that's with our CMD. So as soon as he calls, I might have to push. Okay, okay, just a minute. Are you able to hear me now?
Yes, much better now. Yes.
Okay,
So we
perfect.
can start with your presentation, and I believe the other speaker will be joining around 7:30 perhaps.
Okay, okay,
So
okay.
yes, so please.
Yeah. So I think I should thank all of you first for inviting me. And I am not an academician, but I have been professional throughout my life, more than 25 years into this industry. And I will try to justify the topic given to myself. But I thank FMS team and especially Dr. Uma and Dr. Venkat for giving this opportunity. Please feel free to ask me any questions around, and moderators can note down and ask towards the end as Dr. Hemant, you feel right.
Yes, so kindly, like all the other sessions, please start typing your questions as and when they arise in the chat box. I will try to summarize them and then ask them in, sort of put them together in bunches of topics that we can ask Mr. Kishore.
So, are you able to see my full screen?
Yes.
Okay, okay. So that's so the topic types of and sources of health data, and I think this is one topic which um, is now putting waves around along with COVID, and everybody is looking for health data, starting from academicians, industrialists, research people, and everybody is around this health data. So some of the quotes which I could quote here is the future of connected health will rest more heavily in the area of analytics and data. The physician patient relationship is forever changing, now more than ever with the rise of excess of data. The world is one big data problem. And so these are some of the quotes which will help you all understand what is the importance of data and how it will take the future of it. Now, when we look at so when we look at what is health data, I think I have put here purposefully this picture. It's a ocean or ocean around. and it is so wide that it will cover every aspect of our life here. So, medically speaking, if we look at the definition of McGraw-Hill, it is epidemiology information related to health conditions, reproductive outcomes, causes of death, and quality of life. And you all are doctors, and you will understand what is health data. But as per legal aspects of it, we look at health data, which is defined in our PDP bill of 2019. It is data related to the state of physical or mental health of data principal. Now, when we look at data principal is the consumer who is owner of the data, and that includes records regarding to the past, present, or future state of health of such data principal, and data collected in the course of registration for or provision of health services, data associated with the data principal to the provision of specific health services. I know it is very legal terms, but anything which is related to data principle, which is recorded uh, in the state of physical or mental health, that is regarded as the health data here. Now we look at something very important here, which will give you a perspective of it. Is this COVID pandemic has brought to light, I think, importance to digital health services like booking appointments to hospitals for a vaccination or a regular treatment, finding the availability of a critical care bed, booking the home sample collection for lab tests, ordering medicines. I think the proposed, so we have NDHM, which is ABDM right now, has a lot of building blocks around to envision and solve the challenges in delivering the healthcare services. And I think most of you would be aware of these. So the data which we look at has a lot of health data from patients to individuals during each encounter. And now, what is the problem here is most of the doctors provide a physical copy of health report to patients. Now, how do we carry it forward? So these may be diagnostic report, discharge summaries, prescriptions, clinical notes. Now, in patient case such as OT, notes are currently not shared unless requested by the patient. So we have a lot of areas where we have to work around. Government is working towards it, and we as AMTZ have a lot of participation in those areas of consolidating the data across. Now we move forward from here towards the ecosystem. Now I have specifically took this ecosystem from the national stack of it. This is the sources of health data in this ecosystem. So we think that the data is from EHR, labs, clinics, pharmacies, biomedical images, genomics, civil registration system, hospitals and health providers, social media, published literatures, supply chain management. Now we look at all these things, but let us classify all these things into more robust form and look at everything is around citizens and patients here. Now, when we look at citizen and patients, who is concerned here? What is the vertical here? So we look at providers, which has hospitals, clinics, lab, pharmacies, wellness center. No, we know everything about it, and we look at on everyday basis. But it is the data is isolated. It is in solos. Do we look at can we say that my one patient from one hospital going to the other hospital can carry forward? Is it interoperable? So that's where we need to find ease of the data transparency, data efficacy towards each other, towards each hospitals and clinics. The labs are able to share it. Then we look at the allied private entities like TPA, insurance, health tech companies. Now, do we have those aligned to the healthcare providers, hospitals, clinics? They do have one bench where everything is isolated. They are not interconnected to it. Do we have a ease that when a patient goes with a health card ID? So I think that is one thing which the across India health ID has been launched across India, and a lot of people are working making those health IDs, which is just like UPI. So if Dr. Rashmi Chopra has, so it is Rashmi Chopra at NDHM. So you just have to simply go to the hospital if it is registered with NDHM or ABDM to give that that UPI ID, and it will be the data can be accessed. Now, for that, a lot of infrastructure is required here, which government has already put a stack. I will be discussing that part also, so that we are aware of things. So we also look at the healthcare professionals, practitioners. What do they do? What is the prescribed limit? So if there was a general survey across which says how many people buy prescribed medicines from pharmacies across, so it is less than 50% across in developed nations also. Then we look at the data which is generated by non-profit organizations, associations, NGOs, data for regulators who create standards across. So NCRS, RES had MDDS, metadata and data standards, which do talk about FIR, HL7, DICOM, PACS. So those are consolidated into 32 MDDS standards, which will be used in ABDM. Then we have a lot of program managers, directors, administrators of hospitals who need data. Then state governments and central government require it for policy making. So this is the complete ecosystem from which we can get the complete data, and this will become the backbone of integrated digital health infrastructure for the country to bridge all the gaps. Now, let's look at some of the pieces where, as a doctor, you are doing a particular research. Are you able to get right number of patients, right demographics, right geographies for it? So that's something which we should look at. What is the ease of data availability? Now, when we talk about ease, it is also something which we look at. Do we have data classification? So we have health data classification available, like personal health data and non-personal health data. So I have given the links in each slide, which you can use to get into detail of those subjects. So I'll not go into deep of these subjects, but these are very important. That whenever we collect data, right now the PDPB is in, but Act has yet not come in. But whenever it comes, it will be very strict norms across. So how are we treating the data of? So once we start recording those data into information technology systems, into HMIS, how are we keeping it? Are we taking consent from the customer? And all so when we talk about personal health data, it is all the detailed information of various health conditions and treatments given to the patient. So that's where we talk about interoperability. So I would go to one simple step of it. So let's say if you are working on Excel, a particular data is there, and you want to work on a statistics over it. Now you do classify on the header of Excel the fields of it, and when you start making a pivot of it, you have to standardize it. So sometimes, let's say I have this sheet which has come to me. So if I look at how many dental doctors are there in this particular group, I would not be able to make it up, because somewhere it is orthodontist, somewhere it is dentist, somewhere it is dental graduate. So are we standardizing my data to use it for the information that is required? So when I look at it, what is the percentage of doctors or dentists who are doing this MBA? What are they going to do after MBA? What is the stream of it? So at this point, I will particularly stop here, and people, I want to listen from them to understand what they want. Let's say if I ask dentist, so after this MBA, what they want to do, where they do want to see themselves 2 years down the line or 5 years down the line.
Rajesh, Savita, where do you see yourself in 5 years? I think it's a great question.
Okay. So, sir, as presently I'm working with medical technology company Striker, and I want to utilize like managerial skills from this course to upgrade further into that organization, maybe on some senior level, and handle some particular team regarding to some particular device.
Okay, so I can see, Dr. Savita, your job role is ensuring data collection of clinical research should be
Yes, sir.
consistent, accurate, and in compliance with defined protocols. When you
Yes,
give
sir.
this particular statement, I think you are clearly defining the data should not be as a data it in our raw data. It has to be in a form which can be utilized further. That's how you
Yes.
can do your clinical research for it. So when you're doing a clinical research, so we have a very large ICMR big animal facility here, which is approved very recently. And when we look at data collection for a particular drug or medical device deployment, what do we look at? Can we integrate those devices into the system and collect the data of each and every minute, each and every second, what is happening? Then only we can recommend that this particular device is accurate. Can we take that risk with that patient? So, what is the quality standard? Are we adopting to international standard? What is the we are also looking at things when we say our products, our research is as per international standards. So when we say international standards, are we compromising anywhere? Is it a solo research that we are doing? So all this comes back and boil down to data. Now, let's say Dr. Savita is here. Do you want your data to be publicly available?
Yes, definitely, but it should not compromise with patient identity, I would say. So we have to de-identify like his name or anything that would lead to his recognition.
Yeah,
So yeah.
sure. So we'll come back to this answer in
Mm.
my next few slides. Anybody else?
Yasser, in your clinical work, uh, uh, what would you want to? What kind of data would you look at in your clinical work?
Good evening, sir. So whenever we are planning to do some original research, we have to collect a lot of data. And suppose if we send it for publication also, many of these journals require that all this data has to be uploaded on their website. But then, yes, we have to remove all those personal identifiers. That is just the clinical data which needs to be uploaded. That is now a requirement for publishing original articles and research.
Yeah, absolutely, absolutely. So, so when we publish our articles, it is being checked: is it a duplicate publication or not? And we look at what is the content. It is being given to various committees of who check, go through it, and see the publication, give comments, and then there's a long process of it. So that's how I think we are maturing towards a more professional approach towards it. So do we use some tools for gathering clinical data, or is it purely on paper and we transcribe to Excel sheets, do some statistics and show? But this is a kind of a silo operation which is there. How your research is helping country to implement that research into a product. I think that's something which will happen once we have more authentic data, more geographies and demographics covered towards it.
Right. So whenever we are doing some kind of a retrospective analysis, so we need to extract data from the HIS. So we get all the medications that have been given, the lab tests, even radiology reports. So we can get all that from the HIS.
Yeah.
If
So
it is
yeah, absolutely, Dr. Yasser. So let's say you are collecting from 10 hospitals. Now, how do you ensure that your data is in the same format?
Yes. So yes, that can be a problem because each hospital may be using a different kind of HIS. So even if we are extracting data, they may be giving it to us in a different format.
Absolutely. So that's a problem statement here.
Yes.
So when you work on data, so that's what I think ABDM is working towards is to standardize through FIRE HL7 standards that we use particular standards to collect the data and to store it, and through Health ID you can get the information pass on it, and we use a lot of APIs to look at it. So, any further questions, Dr. Hemant, or shall I move to the next?
Yes, please.
Okay. So let's so carrying forward Dr. Yasir's point. So I'll just tell you the horizon of the data here. Don't go into the nitty gritties of it. So we get we have Arogya Setu, we have eSanjeevani, we have HMIS, we have LMIS. Different public and private innovations are there in user applications. Now, how do they talk to each other? That's where the unified health interface comes here, which says APIs, application program interface for health services. And telemedicine is on a rise now. So we can discover the doctor, we can book appointments, we can get e-prescription. So we get a lot of labs and drug reports online nowadays. We also now have a lot of aims which is covering the discovery of bed availability, hospital facilities. But since still the private hospitals don't have that shown publicly, what is the bed availability, emergency services availability. And once all of these are transparently shown, it is handled. So that's why the health facility registry has come, doctor registry has come, the healthcare provider has come into this. All these translate into health data exchanges, where the health ID remains a primary for a citizen, and healthcare professionals can use these health ID to jot down the e-prescriptions, any lab reports they have, health claims they have, and the doctor can carry forward, the patient can carry forward it to the next hospital and have all the information ready, and not on a hard copy per se. And specifically on the public utilities like Aadhaar, UPI, DigiLocker, and so on here. So this is the particular stack which is being used, which will be useful when you go to any clinics or hospitals, where you know that everything is getting towards a unified health interface. Another data source which we get a lot of data across is the SDG
Excuse
goals.
me, sir.
Yes, please.
Sir, the format that you showed, the dashboard, is that standard that will be followed in all the hospitals, clinics, everywhere?
There's a consultation paper on it. It has not been implemented yet. So there's a link given in the PPT which I can circulate to Dr. Venkat, and he can share it with you. So this link has all the details about ABDM stack. Yes, this is the standard which has been given for interoperable.
So, Mr. Kishore, who will define these APIs? So, is there a body that is now entrusted to set the API standards for nearly everything?
Yes, NHA is working on it towards it to make all those things as standardized. And there is a India architecture which is being currently used to consolidate everything. But right now it is in consultation phase, and all the consultations have happening. And shortly, I think it should be implemented across. Health ID is definitely implemented across.
If I understand, and then I'll probably translate in English for the class. So these would be publicly available APIs?
This is right now also publicly available sandbox and NDHM sandbox.
Okay, so all these APIs are currently available.
Yes.
And they will keep modifying till they are finalized, and they will be publicly available. So any application that wants to call these APIs,
yes,
will be able to do that depending on whatever security or whatever other issues are there.
Absolutely. So that's why I have health data exchange here written here in the third row. So that is like a NSC or a BSc, which will be using as health data exchange. So one hospital can call that exchange, and that will call to the another hospital, and the information exchange will happen from the unique ID of health ID. Did I answer that?
Yes, thank you.
Sir, I have a question.
Yes, please.
Good evening, sir. Sir, I have been reading about the importance or the integration of artificial intelligence in healthcare, how we can utilize it for the diagnosis and prevention and for improving healthcare. So they said that one of the biggest challenge for the artificial intelligence to be incorporated in the healthcare is the data that patient record, the electronic health record which we are recording, they are not in the same format. Matlab, specified
यूनिफाइड नहीं है, नॉट कहीं पे कुछ फॉर्मेट यूज कर रहा है, कहीं पे कुछ यूज हो रहा है. So are during in this ADHM, ये आयुष्मान भारत digital mission, in this are we working on this कि the patient record which we are recording should be in a unified manner,
Yes.
so that it will ease the utilization of this data later on for the further treatment options.
Yes, of course.
Okay.
They are using FHIR, FHIR, HL7 standards as one of the base. So
Okay.
there is a NRCES has launched MDDS, metadata and data standards, for all kind of interface. For EMR there is HL7, for imaging there is a DICOM, for like MRI and CT scan there is PACS. So all these are standards for information exchange and standardizing of those things.
Okay, thank you, sir.
So, Dr. Hemant, please do correct me if I am going anywhere wrong, because you are also, and you're on mute, Dr. Hemant.
Good evening.
Yeah, Mr. Manish, if I may just add.
Yes.
What I think what she wanted to know was more about structured data fields and not about the standard of information exchange. Because standard of information exchange is that, okay, from across all different data that are available, what standard we will use. But I think her question was that, we don't capture data in a structured format. So if
Same format,
writing
yes.
a text, somebody's writing it textual, somebody's have a drop down certain fields, someone using a different terminology. So that is what her concern was, that when everybody is writing it in a different manner, how do you, collate everything and make sense out of it?
Yes, ma'am, exactly. Thank you.
Yes. So that's what I said, Dr. Uma, that we have MDS, metadata and data standards, that has been defined looking at all these HL7 DICOM. So there's a standard metadata which has been published already by government, which has to be used by all HMIS service providers if they want interoperability to happen.
Okay, all right.
Okay, thank you, sir.
Yeah, students, please allow him to complete, because he has only a few more minutes left. So let him complete. Afterwards, if he finds time, he can respond to your questions. Okay? So please let him allow him to complete his presentation.
Yeah. So thank you, Dr. Venkat. So another source of data where you have a lot of public data available is SDG India 2030 and WHO International, where you will get child and maternal mortality, reducing malaria, tuberculosis, polio. For research purposes, you can get a lot of data on these three sites here. And the movement of our SDG goals towards good health and well-being can be seen here in this particular slide I've shown. And then in India, we have health data management policy. So we were the front runners in declaring those health data management policy, although the Data Protection and Privacy Act is still not related, but health data has been announced. Now, the key objective here is to set out framework for securing secure processing of the data, safeguard of digital personal data. So how do you secure your data? Now, to create a system for digital health records. So, like the last question which Dr. Bhavna asked, how do we standardize the data in different HMIS? Importance of data privacy. So the data of individuals do not go out until the consent has been taken. So there is larger role of consent manager here, and so that we enable the portability and provision of health services. The patient can carry from one place to other, and it is all analyzed. And when we talk about portability, there also has to be a mechanism for auditing purpose, which will encourage stakeholders to adopt different ecosystems of data protections and the policy and the data privacy standards. So this has already been launched, and it is present across. Now, who are the stakeholders into this data management policy? So there will be individuals, health information providers, governing bodies, healthcare professionals, pharmaceuticals, payers, and research bodies. They have role to play, and I have listed the ministries here who will be involved in this particular enforcement of this health data management policy. Now, there are various tools for data collection by agencies, which is there, given by WHO, data.gov.in, and NRCES. So they are free and open source data collection where their APIs are available to get the data based especially on the population based resources, household surveys, civil registry systems, vital events, and this is available. This can be a good source for your research across. Then looking forward, we look at four major points in the data, that the quality of data has to be there, trustworthiness, uh, we promote interoperability standards, and protection. So these are the four principles on which the NDHM and the government is working towards. And as a professional, we should also work towards these things so that the data is comprehensive and we build a united health data community which will boost collaboration in the complete ecosystem. And while doing this, I think we should also look at the information or cyber security. We should have governance and trust structure across in managing all the data across. And I have given the link here downstairs, which can be looked for the detailed information here. And we should look at why data is important is to get the information. Now, information is for what purpose? It can be for improved patient predictions, reducing fraud, employee health record, EHRs, enhanced patient engagements, telemedicine, medical imaging, smart staffing. So in a hospital, when you're working, you look at how can I optimize my staffing. So I had a question on AI. So here the AI engine can definitely work on the patient traffic and the doctor's timings, how it can be optimized and how they are not burdened across. Then we have real-time alerting and augmenting critical treatments across. So we have a lot of work on artificial intelligence, especially in radiology and pathology. We have started working on ophthalmology also. This will give us risk and disease management opportunities towards it. And we are also using in Indian Biomedical Skill Council learning and development programs based on all the data. And we can also look at integration of medical devices and patient monitoring so that all information flows together into one bucket here. So this will give you complete and why the data is required and where all we can use. I've given some use cases here across. So that's it from my side to just an overview of what has been done across. Thank you.
Thank you, Mr. Manish. This is very, very useful. I am extremely, it's an experience for me because I was recently delivering a talk on TV, private sector engagement, and I was quite pleasantly surprised to see that there is a source from where one could gather all the data about the number of private facilities, diagnostic facilities that have been so far listed out in terms of the numbers, not exactly mapped as such. So we are about 40 years, behind in terms of some of the countries like US and Europe, and we still have to catch up with that kind of a data requirement. So if although I have plenty of questions at this juncture, but for the benefit of time and for the students, I will request if there are any last couple of questions. Vikram, you raised your hand. I'm sorry, if you can finally make this possible within next couple of minutes, and maybe.
So, Mr. Kishore, how much time do we exactly have before you have to leave? Then we will accordingly.
I think another 5 minutes.
5 minutes. Okay.
That's correct.
Vikram, short, sharp question.
Good evening, sir.
Good evening, Vikramji. You can call me Manish. I'm.
Sorry. So I just wanted to know, sir, are we actually heading towards converting the all existing data on various platforms into one universal format, which can be made use by everyone? We all come on the same page. And sir, are we also planning that in the coming future, all the small private players will actually run it, and government will provide all HMS, IHMS, one platform for all the digital data collection, at least in India.
So definitely there is a thrust towards it, and but it is always it is currently made optional, and the rollout time is a little longer, which is there. But the platform has been made, and there is a data fiduciary which has been made in data protection, which will be serving as a health information exchange towards it. Every state can have one, and private players also can align to it.
So that means private players, not just the hospitals and healthcare industry, but also the insurance industry as well.
So you have to be a data fiduciary to store the data.
Correct. Correct. Thank you, sir. Thanks.
Mr. Kishore, how are we cleaning these huge data sets? I mean, one of the questions is that such huge amounts of data are planned to be sort of collected. Are there some mechanisms in place to deduplicate, weed out spurious information, check for veracity? If you could just quickly comment on that.
So there are software development companies who are engaged into data cleansing and converting into the format which is required for interoperability. And it is tough. It is tough, definitely tough for completing this task. It's a humongous task what we are going towards it. But I think time would tell how fast we can move. So if I can tell you, 10 years back or 5 years back, when we look at the digitization, the digital wallets or digital payments were one of the things which people were questioning. Will we reach it? And now we are the highest in the world.
Yes. I think we have a great platform for ourselves. I have no doubt, especially with the unique identity that we have. I think that whole India stack that is now available in terms of authentication and presence and a payment system, that is a great foundation that we have for any future applications that we want to build. I think you would have to believe this was really informative. We wish we had you for longer, and maybe 6 months from now or next year, we would love to have you for a much longer session, Mr. Kishore.
Sure, I would love to.
Thank you so much for your time. Dr. Nambiar, would you want to say anything before Mr. Kishore leaves?
No, I just want to thank Mr. Manish for agreeing to come and address the students and discuss with us. I think we can have a session where, as you said, AMTZ also has, they have, I don't know now what is the number, but this is the only medical tech entrepreneurs collective, so to say, in India. So this is all, so I think it's a great group of people there. And we could perhaps have a further interactive session when we have more time. I will touch base with Mr. Manish once again to do that.
Surely, would be happy to host you all here. I think this is a great facility, and one should come and see. You will. I should not. That's why I didn't show any PPT about us. We don't believe in those things. We believe in you come and see what we are, and I can assure you, you will at least say wow.
Oh, that's great.
Yeah, and it's the only one of its kind in India, so I think it's worth that interaction and visit. But we will definitely, Mr. Manish, we'll like to have a session with some of those companies, the entrepreneurs who set up companies there, some of the doctors who are there who consult with companies. That's a great platform to learn for people who are going to be in the space of healthcare in the country, because there's so much happening here. So that's what it is. Thank you very much for being with us today.
Thank
and
you.
I don't want to take much of your time. Thanks once again.
Thank you so much. I just want to add before I leave, we have two incubation council. One is Atal Incubation and other with BIRAC. So Medivalley and BioValley, where we have full trust in calling in startups and innovators. We have a World Incubation Hub where we host and bring the startups to a level where they go to batch and production for their ideas, not only just bring into ideas. and we give a lot of importance to startups here. And we have a lot of examples where people have gone from a startup to a production house. And the import dependency when we started AMTZ was above 90%, and which we have brought down to 60% now. And 90% of India's RT-PCR demand is being pushed from here, AMTZ. And we produce more than 10,000 oxygen concentrators, ventilators, MRIs. So starting from a mask to an MRI is being built here.
That's really wonderful to hear.
Yeah. Thank you so much.
Thank you, Manish.
Thank you, sir. Thank you.
Hopefully, we will have a greater space for you. We are planning to have this 50th year of this program sometime next year, starting from next year. And hopefully we will have a large gathering of industry experts to come and celebrate that. So I'm sure we'll keep that in mind when we invite people. So I'm sure you will be one of them.
Thank you so much, Dr. Venkat. It was pleasure here, and thank you all the doctors for hearing me out patiently. And thank you once again, Dr. Mahan.
Thank you. Take care.
Thank you, sir.